Namaskar. Welcome in this live interactive teleconference of MBA in Healthcare and Hospital Management program. Today we are going to discuss about the facility planning in hospital. As you know, hospital is the one of the complex structure currently providing various kind of services to the patient, and the modern hospitals are very much different. There are many facilities available, including the different kind of safety measures. So you need to plan the hospital very properly for the efficient utilizations of the resources and maximum benefit of the patient. To discuss all this issue, we have expert Dr. Bidhan Das. Welcome you, sir, in these sessions. Dr. Bidhan Das is very experienced in hospital administration, having several decades of experience in this field, and he will share his viewpoint about this topic. And if you have any questions during the sessions, you can call the studio in a given number on the screen. So, sir, you may kindly take the sessions for the benefit of the student.
Thank you, Dr. Biplav. So today we'll discuss, as suggested, discussing about facility management or facility planning. So apart from facility planning, we will also touch upon the safety issues concerning hospitals. So regarding facility planning, how do you plan a hospital of any size, shape? So we'll talk in general for a 100-bed specialty. 100 bed. Now, whether it's a super specialty or a general specialty hospital, that has to be answered first. If it is a super specialty hospital, then what are the super specialties? Because the requirements of each super specialty will be different. If it is general specialty, fair enough. I mean, we can look at that. Now, considering a 100-bedded facility, the normal benchmark that we follow is 1,000 square feet per bed or 100 square meters per bed is the total built-up area. But these are easily said, but practically when you increase the floor area, so the cost of construction also increases. Therefore, we have to optimize that area. So we bring it down to almost 700 square feet per bed. So looking at 100 beds, so 100 into 700 is equal to, let's say, 70,000 square feet. So that is the total built-up area. Now, how much land do you have? So whether you have 1 acre or you have 2 acres or 3 acres. Now, 3-4 considerations are there. First is the ground coverage. Ground coverage, according to the bylaws of different states and different cities, is varying between 35 to 40%, maximum 35 to 40% in India. But prudent will be around, keep it around 30%. 30% of the total area. Yeah. Supposing we are looking at an area, I'm giving an example of 1 acre, and which is roughly around 42,000 square feet, roughly around 42,000 square feet. So 30% of that area has to be the ground coverage. Then the second consideration that we have to look at is the FAR. By and large, the FAR usually for hospitals is around 2. But certain cosmopolitan cities, large cities, they have increased it to 5, somewhere around 6. Like
depending upon the places.
Yeah, depending. If it is Mumbai, then it goes beyond 6. Places like Bhubaneswar, it is 5. So floor area ratio or floor space index, FSI, either whatever you can call. That means if the plot is around 45 or 42,000 square feet, then you can do 5 times of that.
But in this context, sir, there is a common argument people are always giving, like this regulation is only within the municipality area. And if somebody is building into the out of the municipal area,
if it is a rural area, then of course the panchayat,
this rule is not applicable for this hospital.
Yeah, you have a point there. So, yeah, that is right. If it is a development authority like Delhi Development Authority, Bangalore Development Authority, LDA, Lucknow Development Authority, then as far as the authority or LDA's territory is there, it will be applicable though. If it is in rural area or semi-rural area, then unfortunately it doesn't apply. So there you can have a look at the panchayat and do whatever you want to do. But generally we are looking at the correct practices which has to be followed. Now considering the FAR, let's say on a modest scale if it is 2, so we can probably build around 84,000 square feet. How much we require? As I mentioned, it will be around 70,000 square feet. So once the ground coverage is 30%, which I said, so 30% of 42,000 is, let's say it is around 14,000 square feet. So if each floor will be 14,000. Now whatever floors you are doing on the basement is free from FAR. So you can do one basement, you can do two basement, but the cost of construction of a basement is also very high.
Yeah.
So what we are looking at, 14,000, 70,000 divided by 14, it's roughly around 5 floors, so ground plus 4, which is a modest size building, you know. So that is how the planning is done on the basis of the available land and the requirements and so on and so forth. Now comes the tricky part, where do you put what? So it is assumed that yes, the ground floor is a premium space, so we have to put the OPDs, the diagnostic, the physiotherapy, but nothing is sacrosanct. You can have OPDs in multiple floors because you have got elevators, you have got ramps, so people can go up and down. So modern hospitals, they can have OPDs in any floor. I'm just giving you a typical example. Now, in the first floor, what do you want to do? Second floor, there was a theory, once upon a time, that all the operating rooms and the ICU shall be on the topmost floor, which will enable restriction of movement of traffic into that floor. Again, that has become a little obsolete because air conditioning is important, and that is the HVAC. So wherever you have HVAC installed, so you can have an operating room and ICU. Now, therefore, there is another nomenclature, terminology, which is called service floor. Service floor is a sandwiched floor between two floors in which the height is 7 square feet, 7 feet. That means it is not for habitation. So you can use all the plant and machinery, and that floor is used for services, servicing the plumbing, the electrical, the HVAC pipelines. But people misuse it, and sometimes they enable medical record department or offices to be.
It also may be concerned for the safety.
Yeah, that is a safety issue also, but then that is how people misuse that floor. However, coming to the basement, you can do one or two. Technically, the law says that basement shall be used only for parking, but people here also put plant and machinery and MGPS sometimes. Kitchen is strictly no. You can't have kitchen on the basement. Then you will not get a NOC fire. Because these are regulations that we need to comply with and obtain before the approval process is. So we are looking at, let's say, the scale of accommodation. How much is the accommodation that is required? I gave you a little idea how the accommodation shall be calculated. And then 70,000 square feet is divided into OT, ICU, OPDs, emergency. Then you have got wards, you have got dialysis unit, you have got endoscopy units, whatever you want to have, laboratory, imaging, and so on and so forth. And you do the space apportionment. In certain areas, so we have certain regulations like blood bank, if you want to do blood bank. So earlier it was 200 square meter, now it has become 150 square meter. That is called the scale, When you are doing a medical college, because there is nothing to plan, everything is given in NMC. So you have to look after the NMC guidelines and take up for a NMC hospital of 150 admissions or 100 admissions, 150, the total built-up area for the hospital will be around 3.5 lakh square feet. Of the medical college will be less than 2 lakh square feet. And then you have various hostels, boys and girls hostel and so on. So those are the planning considerations that we need to make. But before going further, so we need to have an accessibility to the electrical connection. Where shall we get the alternate sources of electricity has to be also planned apart from the water. So these two things are important. Where you will source water, municipality water or bore well or something. When we look at electrical system, the class before we had a discussion on electrical load and consumption and how you want to calculate the electrical load on the basis of HVAC and the medical equipment load and the light load together becomes the total load. That is how we calculate. Ventilation is now become HVAC. So earlier the old theory was cross ventilation. So now everything is why HVAC.
AC.
So whether you want to do HVAC in all the whole building shall be HVAC or certain areas of the hospital like the OT, the ICU, the OPD, the lab, the blood bank, that is for a decision which needs to be taken. Water supply we have discussed, plumbing also we have suggested. Now this new thing which is now complying with the biomedical waste, which is called the ESTP. So when you put a ESTP and then the wastewater thus treated, are you going to reuse it or you want to let go to the municipality drainage system? If you are going to reuse it, whether you are using it for gardening or for flushing. In case you suggest that you want to go for flushing, then of course another pipeline has to be added onto the main pipeline system. Landscaping, yes, surely we need to have a good landscaping because it will give you a good feeling, inviting feeling with pavers. We can have walking tracks, we can have flowers, we can have water bodies. There are very many ways of doing the landscaping in and around. And sometimes you don't have a basement parking, you can do surface parking. But the whole issue is before doing the planning, we need to give the setback. Setback is around 6 meters, which is through and around the land, so as to enable the fire brigade to go around and in case of the event of a fire. We need to look at MGPS. MGPS, I think we had discussed, medical gas pipeline system, which is again a manifold room has to be complied according to proper ISO standards. The proper color coding is required, and of course the whole, whether you want to give a pipeline system to all the beds or select beds. Select beds could be emergency, ICU and OT and certain single rooms. But you can take a call, all beds you can do. So there is a riser for the oxygen, there is a nitrous. We discussed about suction and compressed air and also CO2.
Yeah.
CO2, carbon dioxide is used in the operating room, but sometimes if the consumption is not too high, then you can manage with a cylinder. But if the consumption is reasonably high, then you can take because CO2 will be used in laparoscopic surgeries. So then you can put it a pipeline also. Elevator, which is lifts, and of course dump waiter we discussed the other day, which is used for the connecting the CSHD to the OT. So there are two lifts, one brings the unsterile items and the second takes the sterile items. Telephone, EPBX, firefighting and access control. So now everything has become automated. So that day we discussed about building management system, and there is something called integrated building management system. So building management system looks after the air conditioning and HVAC. So it's a software, and you can have a desktop, and from the desktop you can control the temperature, the relative humidity, the air changes per hour, and all the criteria that you want to maintain. Integrated means it is integrated with the electrical, the firefighting, the fire doors, the access control, everything. So it's an integrated system of.
So it will be not happen like during the fire accident, the
everything will open.
Emergency is not opening or somebody is searching the key.
Yeah.
It should not happen like
that. It doesn't. It will not happen. It is, everything is integrated and it goes. That is a big role to play in hospital safety. So if you look at hotels, all the hotels are not fitted with these kind of systems. Certain hotels are, like not to take a name, but yes, the luxury hotels of ITC, where the Honorable President of the US, they stay. So the building itself is highly secured building.
Secure building.
Whereas that doesn't really happen in all many other buildings.
Buildings.
So we are looking at the space model which we have discussed. Engineering grade is the grade which we take, which can vary from 1 meter to 1.8, it depends. Ward area, we assume that around 70 square feet per bed into number of beds plus 30% circulation. ICU 150 square feet per bed into number of beds plus 30% service. This 30% or 35% will be a matter of discussion depending on the corridors and the lift wells and the elevators. So sometimes it goes up to 40% circulation. Because the circulation you need 2.4 meters should be the width of the corridor. And of course there is a lift. So there will be a passenger lift, there will be a patient lift, there will be a service lift. So there are some guidelines on account of NBC National Building Code, and we have to follow the guidelines. According to the floor plate, the number of lifts are also calculated.
Sir, is this kind of norm is different for like different accrediting body like Joint National Commission or NABH or the norm prescribed by the NMC? Are they quite very different, or it is almost similar or just next to each other?
Mostly certain standards are given by the National Building Code, which is not extremely elaborate, but yeah. but facility guidelines are now available. NHM with the IPHS standards, they also have given the requirement of the various hospitals, starting from PSC, CSC, district hospital. NMC has given the guidelines for a medical college. Now, these are all spaces. They only have given the idea of the spaces. What they have missed out is the MEP, or the electrical, HVAC, plumbing, firefighting, access control, and of course MGPS. Only the space has been given. Equipment, in IPHS certain equipments are given, but so these are some variable. Now coming to NABH and accrediting bodies, now they are non-prescriptive. These are accreditation standards. So you have given, the hospital has been given enough freedom so as to create their own system, as long as they are measuring what they are doing and doing what they are saying. So the cycle is called plan, do, check and act. So then the accrediting bodies are and of course they have to be commensurate with the best practices. Now there is another term called benchmarking. If they are they benchmarking their outcomes, first and foremost, are they monitoring the outcome? Second is of course, are they? Third is of course the safety, which we will be discussing today. Now safety, patient comes to the hospital for availing a treatment. Now we do not have a right to cause harm to the patient. And unfortunately, that is what we do all the time.
Yeah.
Well, what we understand is infection control, but there are enough areas where the patient can have a fall, the patient can have a fracture, the patient can commit suicide after jumping from the topmost floor of the building, and so on and so forth. So we will try to discuss these sensitive issues also. Of course, there are some ancillary issues, which is called nursing station. Now, unfortunately, this nomenclature of nursing station has to be removed and replaced with nursing unit. So nursing unit encompasses clean utility room, dirty utility room, pantry, nurses change room, hand wash, and nurses station. So that is a module, and this module has to be replicated all over the hospital, whether it's the ICU, the OT, the wards, and so on. So the duty doctor, and of course certain areas they need a treatment area, treatment room. Then sanitary areas like toilets, So sanitation is public toilets. You have a staff toilet, you have got some public toilets. Then we have rest of the things. Corridor, as I mentioned, 2.4 meters will be the width of the, enabling 2 stretchers accompanied by 2 people each stretcher to be crisscrossing each other.
Yeah.
So that is the
basic purpose.
That is the purpose. And the floor height, So when you increase the floor height, again the cost of construction increases. But you have to maintain a certain floor. At a home, you maintain a floor height of, let's say, 10 to 11 feet. But in hospital, it will not work. So the OT will have a free height of 15 feet, so as to enable the HEPA, the laminar flow, to be installed apart from the OT light.
Yeah.
Same thing will happen for a cath lab. You have to maintain that height because they are on a track. The equipment has to be moving. So the rest of the areas, I don't think we have to comment. But then the height has to be maintained not less than 12, because after all these plumbing pipelines, the HVAC pipeline, the firefighting pipeline, the electrical conduits, you have to give a false ceiling. Now that will take up, let's say, around 2 feet. So you just have a left out with only 10 feet height.
Yeah.
So this is the height consideration. So we need to balance out how much height are we going to make. Are we going to make it uniform all the floors, or separate height only on the floor where we are having the OT, ICU and the cath lab? So one can do that, to save money. That's the only consideration.
And while making the false ceilings also, there are lots of reports coming that these days we stop using some kind of asbestos made
material
product, because these are not good for health. So are there is there any particular guideline, or people are just
there was there's no guideline. So certain things in the operating room, people have a fancy for modular OTs, which which is debatable. I would probably leave it alone. But yes, they need to have a stainless steel ceiling. But plain this thing with epoxy painting will also work. So asbestos probably will not be. That is good for offices and other areas, but certainly not OTs. We have a little consideration of the window, how much window space. We need to have reasonably good aeration. you know. With this now, green building and other things, Griha, so natural light is of utmost importance.
But many hospitals these days, modern hospitals, they don't have a window, although they are having total
Air
means
conditioning system.
air condition and like light is coming through properly, but they don't have window.
So
It is commonly observed these days.
if you do not have windows, then you are prohibiting natural light, and the cost on account of the energy, which is electricity, will be increased. Now, if the admin cost, like the electricity cost, is very high, then surely you will have a count on your EBITDA, and the profitability will be compromised. You know, so that balance we have to do. Walls again debatable, which I said, but normally we can have plain walls and with a normal paint, which is they have a fancy for they have a different nomenclature, antibiotic painting, this painting. It's not required, just normal painting, which will be good enough. Doors are of 2-3 types. Normal doors, then the doors for the OT and the fire doors. So the door hermetically sealed doors we discussed in the OT, wherein the interior air can come out, but the outside air cannot go out. Fire doors, they have a life of half an hour, 1 hour. Like this one is again another type of door in the studio, which is for noise prevention. Light and fire circuits. We have 6 amperes, 16 amperes, and of course industrial plugs for the X-ray machine and the CT scan. So that is the load that they will take. Because the CT scan will take around 125 kVA. The X-ray will take around 80 kVA, depending 300 mA or 500 mA. So this is how these are important on account of the normal power sockets, which is now if you are doing a hospital in India, you are doing a hospital in Kenya or in Tanzania or in Australia, then those guidelines you have to follow.
Yeah. Every state has its,
The
and moreover
French
these
guidelines,
days,
Australian guidelines.
many states within the India, they have their own clinical establishment norm.
Clinical establishment norm was done, and we did the common minimum standards. So the act is couple of pages, but the common minimum standards were divided into right from the doctor's office or a doctor's clinic to 1500 beds, which we have created, and that is an addendum to the Clinical Establishment Act. And you follow, but yes, all the states are following that. Of course, you have to have a generator. We discussed that, first standby and second standby, and 100% backup, apart from the UPS. UPS load calculation. UPS has to be installed at least in the blood bank, the OT, the CT scan, the MRI, the cath lab, the LINAC. All these places you have to have a UPS. Technically, the vendor gives. It is a part of the equipment. But you can have a centralized battery room and a centralized UPS where the cable can connect to the respective equipments which are located in various floors of the building. Now, let us look at the legal and regulatory compliances. First, when you have the drawing and it is submit for approval to the competent authority, so you have to get a clearance from the biomedical or the State Pollution Control Board. So what would they like to see? Whether you have got a place for the curb collection area or the storage area for the biomedical waste, and how the waste will be transported. NOC fire. So you have to get a clearance from the district fire officer, who has to give a clearance on account of that. Are you having a overhead tank? Do you have the staircase width? They will have a depth of the staircase. All these criteria they will have to fulfill. Detectors, sprinklers, hydrant system, things like that. So these 2 clearances are obtained, and then they are submitted for the competent authority for the possible approval. Now the planner or the architect has to give a presentation in front of the competent authority, so and obtain the approval. If they suggest certain corrections, you can do the amendment. Obtaining the approval from AERB. Supposing you are installing a LINAC or a CT scanner or an X-ray, so that has to be done by ELORA. So ELORA is a portal where you can have a registration on behalf of the hospital and submit all the drawings, and wait for a couple of days. They will put their comments, and then you do the amendments and again submit for approval. And usually, human manpower is very important, because that is important for calculating the heat load. Now, which area you are having manpower, and how many of them? How much heat are we generating in the OT, in the ICU, or in the MRI room, or in the OPD? In all the areas, we need to have a calculation of that. Equipment, as I mentioned earlier also, I am not very fond of AMC. I insist for comprehensive, which is inclusive of spares, all the spares. Now, technology, now most of these HIS are now integrating with the laboratory systems. So there is no need for typing out again in the Word format. It will automatically give a printout. Integration into the access control and HMIS is equally important. There are some no-go zones. You can't have an access for everybody can enter into the OT or ICU or the store. Where there is a chance of pilferage and where there is money involved, I don't think we should have a lot of traffic. Calibration and traceability. So calibration is the biomedical equipment has to undergo a sense of calibration, and which for the traceability to international standard. Calibration has to be done by an NABL accredited lab. Statutory obligations, as we mentioned, we need the licenses like pharmacy licenses. Once the hospital is commissioned, we get the pharmacy license, we get the blood bank license, and so on and so forth, after getting the occupancy certificate.
And what about this? Some hospital, if they use some kind of nuclear material, so they also need to get approval from the BARC also?
So AERB is the regulatory body. Three things: nuclear medicine and radiotherapy. Nuclear medicine, you can have gamma camera, you can have a PET CT, you can also have iodine treatment facility. And radiation, it is linear accelerator, of course. There is a CT simulator and there is a brachytherapy as well. Apart from mammography, the normal diagnostic thing. So for them, it is the AERB. So you have to submit all the drawings into ILORA.
Okay, it is also done by ILORA only.
Yeah, it is ILORA. Yeah. So when you do a design, as you asked me, so there are space criteria. Typically for a OT, it is 20 by 20, 400 square feet. The interior is 400 square feet. Now, supposing you are putting a modular portion, so it will eat away 6 inches from all areas. So you are reducing the size of the OT. So all those calculations which you have done as a planner for the OT goes for a toss, because the electrical load, the HVAC load has been calculated on 400 into 10 feet is the height, 4,000 cubic feet of air. The HVAC system was supposed to treat that 4,000 cubic feet of air, whether it is temperature, relative humidity, pressure, air changes, everything. So everything will go for a toss because 6 inches is eaten away. So that is how it is done for a CSSD, as I mentioned the other day. CSSD, kitchen, mortuary, or all these areas, they have a particular workflow. Looking at CSSD, receiving area, washing area, decontamination area, ultrasonic washing area, drying area, packing area, loading area, unloading area. So these all have to go in a flow. Well, the equipment could be a different make and model, which I will not get into what kind of equipment, what is the make and model of each level of equipment. But the planning has to be done according to. So we're doing a blood bank. So blood bank is according to drugs and cosmetics. They have given the space, then the donor recruitment area, doctor examination area, bleeding area, untested blood. Then you go for tested blood, which is testing all the 5 diseases, component separation, then storage, then cross matching and issue. So you have to maintain that workflow. So these are called workflows, and every workflow will have a SOP. Floor. So now we do flooring. There are 3 components. There is the civil construction, which is the core structure of the building. There is MEP, which is called electrical, mechanical installation. Then there is a interior or finish. Flooring will be an important. Flooring will be, nowadays people are very fashionable for granite. You can have granite, you can have marble, you can have PV, polyvinyl floor, but certain things are slippery. Let's say granite will be slippery. So there are anti-skid varieties also available, which are ripped off. You can use PV, polyvinyl, but depending on the decor and finesse of different. But clinical areas like OT, like ICU, blood bank, and what I would prefer to have polyvinyl. There are 2-3 makes which are available in the market.
And these days they are coming in a very good
color, because color, texture, everything is. And it is easy to maintain,
to clean, and
easy to paste,
replace also.
Yeah, they say 5 to 10 years, but it doesn't matter. They will live, as well, because for the walls you need to have a wall guard, for the so for the railings, all the staircases and ramps you need to have side railings. Wall guards are needed if the stretcher hits onto the wall. It does not spoil the wall. The wall guards are also pasted. Staircases and ramps I have mentioned that they will be a part of the circulatory area, and again the 2-meter stands. The width of the staircase has to comply to the district fire authority requirement. Slipping has to be avoided, slip resistant. Now we have discussed for the design consideration what is the density of the occupancy, how much percentage of occupancy, what is the heat load that we generate, avoiding of crisscrossing and unidirectional flow, particularly from CSS to OT and probably also to the ICU. Flow of services. Now what are the services? Laundry, kitchen, mortuary, the dead body will come and go into the mortuary. The biomedical waste will be collected from all the floor areas and going to the curb collection area or the storage area. Now these are the routes that we have to predetermine and so as to prevent crisscrossing, avoidance of hospital acquired infection, and so on and so forth. Because it is good to have a service floor. It is not very right in whichever lift the dead body will come and you transport the food in that lift. That might not be acceptable by the community or the patients. Fire doors we discussed. Fire doors are fire resistance for a period of 1 hour to 1.5 to 2 hours. Therefore, the rates are also used. Centralized air conditioning, we need to have appropriate automatic fire dampers for each floor for the common ducting system. So, ducting is the AHU, where you have locating the AHU and how much floor area is that AHU looking after, and the fire damping system. Dampers are also there. Pressurization of the lift well, pressure and of course fresh air onto the basements. So, these are considerations for the HVAC load. Safety consideration, which is hazard identification and promoting of safety measures, training of our staff. So, what are the identification of risk factors? So, what are the risk factors that we talk? Always we need to maintain a process which is called structure, process and outcome, which is the basis of the quality management system, and consideration on account of patient safety. Risk prone areas. What is the risk prone areas? MGPS will be the manifold will be a risk prone area. Kitchen definitely will be a risk prone area. Laundry will be a risk prone area. Blood bank will be, there is a lot of contamination in that. So, we need to be careful, like laboratories, this floor areas of laundry and kitchen. Infrastructural risks. What are the possible when we are talking of planning? What could be the risk factors? So, any time we have to do a job, we have to do the risk matrix. Identify the risk, put up a mitigation plan, put up a control system. Who will be responsible for mitigating, and classify the risk? Medium, severe, low, like that. So, according to the hierarchy, you can put the responsibility of that kind of risk. So, we need to have infrastructure risk factor called building, vertical traction, which is enabled by lifts, power supply, lighting, air conditioning, water supply, communication system, equipment and staffing. Now, people now have added pneumatic tube, because this enables a little bit of internal circulation. It has its advantages so much, so I will look at advantages more. And in case we want to put a pneumatic system, there is no problem, but it will enable only the sometimes the medicines to be transferred from the pharmacy to different nursing areas, and of course the lab samples to be, and of course thereby the reports also can be transported. Now, of course, we need to have the signage system. We forget while planning the hospital, we forget to install the signage system, at least bilingual, if not anything else, but at least by smoking limitation and patient safety devices, inspection. Grab bars are installed in the toilets, safety belts in all the wheelchairs and the trolleys, in case the patient would fall during the process of transportation. Grab bars are in the toilets. Hotels have, all the hotels are now fitted with grab bars. Patient safety committee to be in place, and unsafe building, unsafe equipment, ill-trained staff and unsafe practices. So, you need to have a facility audit. Now, who will do the facility? But at least the engineer and of course the medical administrator along with certain senior clinician. They should do a facility audit and see. But this is seldom, hardly done. So which is a big issue. Effective measures to eliminate the risk of the hazard. Periodic regular review of effectiveness of the system. You put up a system and how many times will they be cleaned, maintained, CMC guy is coming. You can have a breakdown maintenance also. Continuous monitoring and analysis of sentinel events. So we know what is a sentinel event, any event which permanent damage or death of a patient for no fault of his or hers. Now, facility management terms we discussed in they say suggested is twice in clinical area and once in non-clinical area. You can do it on the basis of a checklist. Well, this is the action plan which I have discussed with you. At least plan, do, check and act. These are some international patient safety goals. Identify the patients correctly. So, you need to have an ID band. It is good practice to have an ID band. Effective communication. Always have a more amount of communication. Not hide to things from the patient or the relative. Improve the safety of high alert medication, so which is high risk medications or look alike and sound alike. Ensure correct site, correct procedure, correct patient surgery. So things can go wrong in the wrong site, wrong surgery. This is a potential risk in the hospital. Reduce the risk of healthcare acquired infection, which you are talking, hospital acquired infection, and reduce the risk of patient harm resulting from falls. So therefore, the belts or the straps around the wheelchair or the trolleys is also. You can have a categorization of hazard identifiers, HAZMAT. So these are called hazards, which are electrical, chemical, biological, fire, and radiation. So these are the possible hazards in a hospital. We discussed about electrical safety. So the other day we discussed about earthing. So the earthing will be important for because you are using a cautery machine. You are using many electrical devices across for patient care activities. So we have to have this practice of switching off and switching on because most of the things are manual in a hospital unless it is an automated system. You can have an automated with a control panel, electrical, air conditioning, fire, we can have automated, but pretty much it is manual because automated systems are little expensive also. Now, we can have trip switches because when there is a overload, you can have trip off and then we can have trip on. Similarly, the generator and the LT panel, so they have to be connected by a bus bar and bus coupler at the AMF panel, so that nobody comes and manually changes into that. Chemical safety is safe storage, safe transportation, disposal, accidental exposure. Chemical, all kinds of acids, alkalis, even this hypochlorite will be harmful.
Which we are cleaning the floor.
Therefore, it is diluted 1 to 1%.
Yeah.
If it is concentrated, it will burn off the floor. And you are using a vitrified tile, it will burn off. So vitrified tiles on the flooring, I would not probably be very happy. Vitrified tiles are good for homes, certainly not for hospital. So MSDS training, material safety data sheet, and its training, and of course spill management for blood or chemicals. Pre-exposure prophylaxis, which is you have to give a vaccination, immunization for hepatitis B and tetanus. Segregation at source of biomedical waste, safe disposal of biomedical waste, sharps, handling of needles and sharps, personal PPE, and needle sticker UNP, pre-exposure prophylaxis and needle sticker, post-exposure prophylaxis. Radiation safety, we will talk of TLD batches, lead aprons, thyroid shield, gonad guards, radiation safety signages, and annual health checkup of all the staff in the. So fire, we know how many types of fire, what are the fire extinguishers that we use in a hospital. We know that it is A, B, C and D. What kind of fires, we'll just quickly have a look. Elements of fire. So we need to have electrical fires, we can have kitchen fires in the kitchen, we can have in the MGPS system. But for all this, we need to have an evacuation plan. And all the staircases and the fire escape plan have to be going towards the assembly point. So people have to be evacuated and leading them to the Assembly point.
Assembly.
So never to give a red light. It has to be given green light. Red means don't go. Green means go. And the fire escape plan should be clean and not used as a storage.
Yeah. Many times it is observed that on the same door some almirah was put or some object was put.
So these are the grades of fire that we are supposed to use. Of course, dry chemical and dry. So normally most of the fire extinguishers are of this material. Renewal at least once in a year. And the date of expiry has to be written on the
every
extinguishers.
But in the same time, the proper training of the staff is also very much important, because they need to efficiently able to use it when it is required.
The problem is training is fine, but the training is on and on, because you think that you have trained them once in a year, they will forget,
No, sir. They moreover, even if they know, the staff
they will not be able to demonstrate.
No. Another problem is the staff got replaced. Next year, new staff will come.
We understand. So therefore, it has to be on and on. So continually.
Even the same staff is after 3 years. If you say, okay, demonstrate me, he may not able to demonstrate it.
I would agree with that. I understand, but that is the problem of the manager. He or she is responsible, and how he does it is his leadership, or she does it how. So these are the fire exits, at least 2 fire exits in an area of 5,000 square feet or 500 square meter. Corridor, as I mentioned, is 2.4, and high fire hazard areas a separate structure with 2 hours fire resistance. So 2 hours fire resistance doors or construction materials. So one is the fire door, which is almost similar to this, and of course the construction material. For buildings more than 24 meter, the refuge. So there are 2 kinds of refuse. One is a vertical refuse, and the other is a horizontal refuse. This has been given by the NDMA, National Disaster Management Authority. Say for any hospital, 20-storied building. So you need to have vertical, refuge area, because the patient, if falls from a 20-storied building, you know what will happen.
Yeah.
So he will fall onto the 18th floor, then to the 16th, and so on. But in a horizontal, though, you can separate A wing, B wing, C wing by the help of a fire door. So if you contain the fire in A block and prevent it from coming to the B block, I think you have saved it.
Yeah.
So that is the purpose of the refuge area.
Is there any particular material that you said that the fire resistant door has to be there?
So this door that you are seeing in the studio is apparently a fire resistant door. And they have these grades: 1 hour, 1.5 hours, 2 hours, 2.5 hours.
Okay.
It is assumed that if you don't take any precaution, the building will collapse in half an hour of the fire. It will burn in normal, half an hour.
But normally the buildings are made of the concrete and other things.
Yes, so they will have a self-retaining power of.
So they really don't burn by themselves.
Yeah. But there is a fire which is coming from the electrical conduits.
Yeah.
It's a fire which is coming from the air conditioning. There is a shaft. So the fire, once there is air movement, the fire will also rapidly.
Yeah, all this material may be burned, but since the concrete
core
is there, core will there, it will remain its own structure.
Yeah.
And these days, most of the things are done by this, you can say, steel structure or
prefab.
So that kind of steel
material
structure will be not easily collapse even after maybe
that will
1
be
to
advantages, but we are looking at the normal standard run-of-the-mill buildings. So, for this, you have to have a riser of the water, the pump room, or which will push the water onto the topmost point of the building and beyond 5 meters. Similarly, the underground tank for fire. So, 150,000 liters for buildings from 24 to 30 meters, almost like 2 lakh liters you must keep reserve as fire tank. Some seismic factors we can, the zones 2, 3, 4, and 5. Africa is X zone, like Tanzania was zone 4. Nepal is zone 4.
Zone 4.
Yeah. So and Delhi is the Afghanistan again. So wherever you are doing you need to understand the seismic factor, and the structural engineer will create that kind of structure.
And it will be tested on the software also.
Yeah. STRAD.
Yeah.
That's the software. Yeah. So that is on account of seismic factors, Rest of the things we know what is a disaster. A disaster we have discussed, code yellow. Well, fire itself is a disaster. These are some occupational hazards that we need to be. So we have this OSHA certification. Again, it's an ISO standard 4000 some odd certification. We need to, that is requirement for wherever the organization is employing large number of people, at least in the CSSD, the kitchen and the laundry that I told you. The some factors that we need to understand for our hospital employees would be infectious diseases, back injuries, repetitive strain injuries, shift work, morning, evening, night, violence, radiation, chemicals, noise, and falls. MGPS, I think we have done enough. Medical gas pipeline system. So there is really a left bank, there is a right bank, there is a emergency bank, there is liquid oxygen, there is oxygen generator. So there are 3-4 types of connections onto the main system, which takes you through the shaft onto the floors, and then there is a dropping, and then we have to install the alarm system. Alarm system is for used for for detecting any leaks. The pressure will come down, because the pressure is for the oxygen will be generated at the rate of 4.2 bars, but by the time it reaches the end point, it should maintain at least 4.1 or 4.2. So either we can have a manual pressure gauge, or we can have a alarm system. Alarm system is automatic, which will detect and probably give some alarm system which is given, and you can detect the defect in the medical gas pipeline system. This is the typical color coding. Color coding is these are gas specific. Oxygen is black with the white color, carbon dioxide is gray, nitrous oxide is blue, compressed air is yellow. Alarm system, I think we have spent enough. Alarm system would be detecting this, fire alarm, medical gas pipeline system, blood bank alarm. Blood bank alarm is they have that temperature, it goes on circulating. Now when the electric power supply goes and the generator is on, there is a lag period, so then it will dip. So if that happens repetitively, the inspecting authority, when it comes to inspect after 2 years or 3 years, then there will be a problem. Elevator alarm system, security and patient emergency.
The same kind of mechanism may be also utilized for these vaccinations also. Cold storage.
ILR, Iceland refrigerator. No? So these are certain issues that we wanted to highlight when you do planning of a hospital. It is not the space planning alone. It has to be commensurate with the equipment plan, the electrical plan, the HVAC plan, the water requirement, the fire escape routes, and of course the non-medical like kitchen, because these are services. Now kitchen, the laundry, they have to go around the hospital. So where are you locating the kitchen? Have you provided a ramp? Will it go through a service lift, and so on and so forth. So just planning a hospital according to the space is not good enough. And also keep in mind on the safety issues, what can go wrong in case of this building is built, is there an issue of a fall, the floor is slippery, or there is a leak, there is a problem on the electrical system, installation system, or air conditioning system. So we need to be having a little proactive on account of decision making, which will prevent probably these kind of safety issues from. So when you ask me about this accreditation system, they are looking more in terms of the holistic. It's just not the space plan. So patient safety is a big issue, or the staff safety. Occupational health hazard is concerning the staff. The poor guy is working in the laundry. He is working in the, let's say, in the kitchen, whole day exposed to CSSD. So once he goes in, he stays there for 8 to 10 hours. So obviously there will be some degree of, are we concerned? Maintenance workers. So have you provided them with dangri? Have you provided them with some safety?
Enough PPE and all other
shoes,
things.
Boots, and so those are issues that we need to be little proactive. Those are concerns for the accreditation body. Now these are called structural standards. What you mentioned, NMC or IPHS, these are all structural standards. NABH or JCI, they are all accreditation standards. So structural standards are different, Accreditation rather.
But
ISO
whatever
will-
standard we may maintain, if at the end of the day patient is not going to benefit,
nothing helps.
then nothing will
Nothing
be
helps,
fruitful
nothing helps, yeah.
of this process.
Yeah. So I would still, ISO is a good standard. So, but that is a process. So structure, process, and these are systems in accreditation.
Because most of the hospital, these coherent problems observed because they may rented the building something
Yeah,
which is
most of the
available and
times,
which
yeah.
is purposefully not designed for the hospital per se, and they just established the hospital over there and done this.
I would, to answering, going further, you can convert a hotel into a hospital because most of the things are in place. They might not be having the infection control program or the CSSD, but they have a kitchen, they have a laundry, they have an air conditioning system. You can convert certain bigger suites into an operating room and do some retrofitting. That is possible, but not a normal home and multi-storied house. I don't think it will be easy.
And last, sir, there is a often observation that or opinion that in the same room where you are putting MRI or all other diagnostic service, it has to be specialized and separated little bit from the other diagnostic or other operating issues. Is it really like that, or there is something?
Yeah, I mean, not really. But yeah, location of the CT or MRI or cath lab or any other equipment of high value is important. Where are you going to locate it? I would have one console like this, and one doctor can see the CT and the MRI both sides. It takes less space and makes life comfortable, easy. As I mentioned earlier, no place is, you can have the OT in any floor. Well, if you are happy, the patients can go up and down, you can have the MRI and CT on the third floor. We are a little old-fashioned, so we say that it will be on the ground floor. But if there is enough facilities for the movement of the patients, I do not think that will be an issue. Anywhere they can go for a diagnostic. Well, gone are those days when you used to have one CT and one MRI. Nowadays, hospitals which are more than X number of beds, which they can have 2 or 3 of such. MRI does not give radiation. CT does.
Okay.
So the space requirement for an MRI will be an equipment room, the MRI room per se, and a UPS room. As I mentioned earlier, I'm not very fascinated about it. I would probably connect it to the centralized UPS, take the, like that. Same has for CT. CT does not have a equipment room. The CT room and the UPS room. And I prefer one console where the doctor can go turn left and right, and
it can be easily visible.
Yeah.
So I think today is the one of the very important topic we have learned about this planning of the hospital. And during the planning, although we have earlier read the different component like AC management, like different gas pipeline management and all electricity management. But today we have looked into the entire hospital in a holistic approach, and primary objective of the hospital is to benefit the patient. Because the patient is coming hospital, he is already in a difficult positions and he wants some kind of relief. And in that period of time, because of our inadequate planning or inadequate management, if we added more burden to the patient, it is not good for as a professional point of view. And we need to do the justice with the availability of the resources, whatever we have. And we are very much thankful to sir. He has given his precious time to explain all these issues in very great detail. And we are thankful to the students who are viewing us, and thankful to the team of EMPC who is helping us to broadcast this program. Thank you very much to everyone.
Thank you.
Namaskar.
Thank you.